Hey, what's up guys? It's David Warren. I'm on my way to work right now. Unfortunately, I can't take the camera inside, but I'm going to give you a little snippet on what it's like to be an ER nurse practitioner, so keep watching. Thanks. Hey, what's up guys? It's David Warren. Thanks for watching. I'm an emergency nurse practitioner, and I'm going to talk to you today about what it's like being an emergency nurse practitioner. So here's kind of how my day starts. I will leave home and I will arrive to work. And when I arrive to work, depending on my shift, we work a variety of shifts, so anywhere from 7 a.m. to 7 p.m., 9 a.m. to 9 p.m., 11 a.m. to 11 p.m., 1 p.m. to 1 a.m., 2 p.m. to 2 a.m., 3 p.m. to 3 a.m. There's just a variety of shifts that we work in the emergency department. And they're all 12-hour shifts. Some emergency medicine groups work 8-hour shifts. However, where I work, we work 12-hour shifts. And so whenever I arrive to work, depending on the shift, I will find out who the off-coming provider is, if there is one, and I will go find that person and find out if there's anything that I need to take over. So maybe they have seen a patient that's not quite ready to be dispositioned yet, so meaning they're either going to be discharged home or admitted to the hospital. If their workup is pending, then I will take over that patient and dispose them appropriately. So either admit them to the hospital or discharge them. After that, I will log into my computer and bring up what we call our tracker board. And our tracker board has a list of all the patients in the department. It has all of their information, so it has their name, and it has their acuity level, and it has their age and their chief complaint, and how long they've been here. And all of that is very useful in determining who I'm going to see first. And so going back to acuity level, whenever you come to the ER, you're not seen on a first come, first served basis. For those of you who've been to the ER, you know that. For those of you who work in the ER, you know that as well. You're not seen on a first come, first served basis, you are seen on an acuity basis. So in the emergency department, we use a 1 to 5 scale. So it's called the ESI triage scale, and it's the Emergency Severity Index. And what that stands for is basically the person that is the most acute or the sickest is the person who's seen first. And that's a level 1. So a level 1 is somebody who is actively dying. So they're having like a heart attack or a stroke, or they're a CPR, or something that is actively killing them. That's a level 1. So a level 2 is somebody who is really sick and who is high risk. So maybe they have cancer and their blood pressure is really low and they've been vomiting a lot and their heart rate's really high and they're running a fever. That person would be considered a level 2 because they're really sick, they have abnormal vital signs, and they have risk factors. So they have cancer, they're immunocompromised. There are other risk factors that we can go into, but you kind of see the idea. A level 3 patient is kind of your standard run-of-the-mill ER patient. So it's somebody who comes in who's going to need a workup, but who's not actively dying or who's not high risk. So maybe it's like a 20-year-old with abdominal pain. They're otherwise healthy and they think they have appendicitis. That'd be a level 3. So it's, again, a kind of a run-of-the-mill typical ER patient that needs a workup, but that is not high risk and is not actively dying or is not having abnormal vital signs. A level 4 patient is somebody who we would consider low acuity, so level 4 and 5 are both low acuity. And a lot of ERs have different areas where the low acuity patients will be seen. So a level 4 patient is somebody who maybe needs one resource. So they need an x-ray, or they need a lab draw, or they need like a CT scan. They need just one resource. Maybe they fell and they twisted their ankle. That would be considered a level 4. A level 5 is somebody who needs no resources. So that would be like a skin rash that you can just visually look at the skin or the rash and diagnose the patient. Or whatever they come in for, you don't need any resources. So you don't need any labs, you don't need any x-rays, you don't need any resources to evaluate that patient. That's what a level 5 would be. And so based on this acuity scale, that's how we see patients in the emergency department. So whoever is sicker will get seen first. So if there's a level 1 that comes in, we'll jump right on that immediately because that person is actively dying. We'll see the level 2s and the level 3s. And again, the level 4s and 5s are usually seen in a different area of the emergency department. For instance, where I work, we have what's called a fast track area. And so the fast track area is where all the level 4s and 5s go. And as providers, we all rotate through there kind of on a different, kind of on a monthly basis. We'll all rotate through the fast track area. So once I've determined who I'm going to go see, I will sign up for the patient, meaning that I assign my name to that patient in the computer, and that means that I'm the provider that's going to be seeing that patient. After that, I will look at their chief complaints, and I will usually go through their chart and determine if there's any past medical history or if they've had any past visits to our emergency department. So I'll kind of delve into their chart and I'll look at past visits, see if they have any problems. For instance, maybe they have cancer and they're followed by the oncologist at our hospital, and I can go into the oncology notes and kind of see what kind of cancer they have, if they're currently being treated, and I can really delve into their medical history if they've been seen in our department. Sometimes they're not seen. Sometimes we get brand new patients who've never been seen, and then we just have to go get all the history from the patient. So I'll start with looking through the patient's chart to see if they've been to our department, kind of delve into their history and their old visits if they have any, and then I will get ready to go see the patient. So where I work, we have people that help us. They're called scribes. And so scribes will be the one to do the documentation for us as nurse practitioners or as physicians. So we'll take the scribe with us. The scribe will go into the room, and as we're asking questions to the patient, the scribe will take down the history that the patient is reporting to us. So when we first see the patient, I'll walk in and introduce myself as David. I'm the nurse practitioner that will be seeing you today, and I'll always ask, how can I help you, or what brings you into the emergency department today? And that gives the patient the cue to tell us exactly why they came in, what's the nature of their visit. And then we go through their history. We talk about their chief complaints. So if they're having abdominal pain, we really talk about their abdominal pain. When did it start? How long has it been going on? How would you characterize the pain? Where's the pain located in your abdomen? Does it radiate? What makes it better? What makes it worse? All those things that we're taught in school. We go through a really detailed history based on the chief complaint of the patient. And then we'll ask some more questions that might be related to the abdominal pain. So have you had any fever? Have you had any vomiting? Have you had any diarrhea? Have you had any dysuria, which is burning with urination? So we'll ask a variety of questions that may tie in or relate to the abdominal pain. And then after that, we will do a physical exam. So we'll actually examine the patient and kind of see if we can see, based on exam, what's going on. After we do that, we'll leave the room, go back to our desk, and I will dictate to the scribe what my exam findings are. So I'll say the patient was well appearing, he had right lower quadrant tenderness, he had no guarding, no rebound, kind of all of the exam findings that you may or may not have on an abdominal pain patient, whatever that may be. I will dictate that to the scribe, and the scribe will then put that in the medical record. And then I will go to my computer and determine, what do we need to do for this patient? So do we need to put an IV in the patient, give them pain medication? Do we need to get some lab work, or do we need to get a CT scan or an x-ray? Whatever we need, then we'll determine based on that what we're going to do for the patient. And then after we put in those orders, then I will move on to the next patient, and I will keep going through that. And after I've seen usually about 4 to 5 patients, I'll start getting some lab results and tests back on the first few patients that I've evaluated. In which case I'll go in and look at those results and look at their lab work, look at their radiology, and then based on that, I will use medical decision making to determine, does a patient need to stay in the hospital or can they go home? So that's really the number one question that any ER provider will ask themselves. Does this patient need to stay or do they need to go? Meaning, do they need to be admitted or do they need to be discharged? And based on our findings, based on our exam findings, the patient's vital signs, their tests, whatever comes back, we'll make a decision. Does a patient need to be admitted or do they need to go home? And then when we have everything back, then we say the patient is ready for disposition, meaning I can make that call. Does the patient need to stay or need to go? In which case, if they need to stay, I will call the appropriate admitting physician or admitting provider. So maybe that's the hospitalist, meaning somebody that takes care of patients while they're in the hospital, or a specialty care. So if they come in with a GI problem, I might call the GI doctor. If they come in with an orthopedic problem, I might call the orthopedist. If they need to be admitted, I'll call the appropriate physician and discuss that case. And then that physician will either admit the patient or tell me to call somebody else to get the patient admitted. And then once the patient's admitted, then we are done with that patient, they're admitted. We put in a different set of orders for the patient to be admitted, and then they go upstairs if there are beds available. And then we kind of continue through the day seeing patients like that. At some point, we're gonna get hungry and need a snack. So I always bring snacks with me. I eat snacks several times throughout the day, take random breaks, go to the break room, have some water, eat a snack, have lunch, and then come back out and start grinding again. So that's kind of what the day looks like as an ER nurse practitioner. At the end of the day, we will do handoff again. So when my shift is over, another provider will be coming on, and if I'm not finished with all of my patients, then I will hand those patients off and say, hey, I have a patient in bed 23 that is waiting to be admitted. I'm waiting on the CT scan to come back. Can you follow up on that for me? And so we'll go through handoff, and that's the process of handing patients off from one provider to another whenever we're leaving or coming onto shift. So again, that's what kind of a typical day in the ER looks like. If you have questions, comment below. Also comment below and let me know what your typical day looks like in the emergency department if you're a nurse practitioner or if you're a nurse. So thanks for watching, and I'll see you next time.